Good morning. Welcome to session 2, Scientific Advances in Diversity, Health Equity, and Social Justice. My name is Trung Pham, and I'm an instructor in the Department of Pediatrics, the Division of Infectious Disease, and I will be moderating this session along with my colleague on the MCHRI Education Committee, Dr. Venkat Krishnan. It is my honor to welcome our first speaker, Dr. Fernando Mendoza. He is a professor of pediatrics and the Associate Dean for Minority Advising and Programs in the School of Medicine. He will be speaking about the diversity of children and the need for transformative pediatrics. Dr. Mendoza.
Thank you. So I'm talking about diversity and the issue of why we need to think about transforming some of the things we do in pediatrics. I have no disclosures. When I was asked to do this, they asked me, can you talk about your experiences in diversity and your experiences in the area of health disparities? And as I thought about it, I thought we really need to think about, as pediatricians, what happens or what should happen as our population of children become more diverse. What's our responsibility? So what I would like to talk to you about over the next 15 minutes is the issues of understanding that the diversity of the US population of children is really important for us to address in the work that we do. That it is, because of that diversity being linked with certain social determinants, going to require us to think about social determinants of health even more than we have in the past. We also need to think about the history of our medical care system, as reported by the Institute of Medicine, that there is significant bias and lack of diversity in medicine, and what do we need to do about those issues. I will sort of use this as the background to discuss my own experiences in areas of health disparities, medical education, and clinical care and advocacy. First, let me just start off with the diversity of our child population. This is data from the Census Bureau, and this is the percent of the population. This is over time from 2012 to 2060. And this line is the 50th percentile of the population. The red line is the proportion of minority children in the country. The blue line is proportion of minority adults. You see that this red line crosses the 50th percentile. And therefore, in 2018, half of all the children in the United States were minority children. California actually passed this 20 years ago, since we are the most diverse state in the country. As these children grow up, they will become adults, and in 2040, half the population of the United States will be minority. Of the population that we talk about here, this is what they look like. The Hispanics are the largest group, Black, Asian Americans. But the other thing we need to clearly understand is when we group groups together, as we do for Hispanics and Asians, there's quite a bit of difference among the groups. In this profile here, you can see how Hispanics look. 2/3 are from Mexico. And the other thing, if one looks at the first, second, and third generation, a great majority of this group is either first or second generation. And this is true for Asian Americans. So the other fact of diversity in our country is that currently 1 in every 4th child lives in an immigrant family. And that means one parent is born outside the United States. This will increase to 1 in 3 over the next decade or two. So we have this diversity that has now become evident to us. And the question becomes, what do we need to understand about it? I think one thing is, what are the resources for those families that come from minority background, that are minority? What are the resources that they have to support the development and success of their kids? I'm going to focus mostly on the Black and Hispanic groups, since those are the largest ones. But if you look for the last 50 years, they have been at the bottom of the income ladder, and have stayed there. And indeed, when you look at population of the children that live in poverty, these are the two groups that have the highest rates of poverty among children. The other aspect of this, and not just the income, but how much wealth does a family have? And since 1963, you can see here, the median family wealth of non-Hispanic whites has really increased. But when you compare that with African Americans, for example, they have only obtained 1/10 of that increase. Hispanics, 1/8. And another aspect of this is to look at whether somebody owns a home or not. 3/4 of all non-Hispanic whites own a home, but the rates are much lower for Hispanics and African Americans, being less than 50%. So we have a diverse population, a more diverse population that looks to be poor, have less resources. One of the ways to get out of that situation, to go up the economic ladder, is to have education that moves you up in the kinds of things that you can do that can make you succeed and be more middle income, so to speak. But when one looks at the educational performance of Black and Hispanic students, you see that for the last 30 years, that performance has been less than whites or Asian Americans. And to the point that when you look at the data, it's persistently a half standard deviation over the last 30 years. As a pediatrician, I not only think about the child's physical health, but the wellness and development. So this to me means that we need to think about educational success as one of our health outcomes. And we can see here that both Black and Hispanic children are not being successful. So as one looks at this issue, what are the things, how do we conceptualize this diversity and the dynamics of more poverty, less education? One of the aspects that I think about is the issue of social determinants. The World Health Organization has used this to look at how to look at a population in terms of determining what are the factors that produce health. And as you can see in here, both the World Health and CDC have identified these factors: genes, health behaviors, medical care, and the ecology or the social determinants of a community or population or family. And at the end of the day, what has become evident that the ecology of a family, or how they live, where they live, is very important. And some would argue that sometimes the zip code is more important than the genetic code. If we take a look at what some of those components are, you see you can list many of these, but clearly poverty, structural racism, and it's today we see on in our society issues of being disenfranchised, the issues of Black Lives Matter because they're disenfranchised from the legal system and policing, and immigration policies. And yet, as we look at things that happen in the ecology, we also have to look at medical care and what are some of the issues that we have to address. As I mentioned, the Institute of Medicine had a report called Unequal Treatment, and after quite a bit of analysis of our literature, it showed that there is unconscious bias in healthcare, and more importantly, that sometimes happens because there's a lack of diversity in the healthcare workforce. And that diversity can be seen, or lack of diversity can be seen here. Since 1980, I became a dean of minority students in 1982. And what has happened since that time is that we really haven't increased diversity. The number of Latinos, African Americans was about 3 to 5%, Asian Americans about 3%. And over the past 30 years, that number has not increased significantly for African Americans and Latinx students. It has for Asian Americans. But the other aspect of this that one has to consider is that if you look back in 1980, the underrepresented minority populations in the country were about 19%. That population has actually grown. So if one looks at the URM, underrepresented in medicine population, in the number of medical graduates compared to the population that they come from. In 1980, we had 46% population equity. Today, we have 35%. It's actually fallen. That also is seen in the faculty. There are currently only 3.5% and 3.4% African American and Latino faculty respectively. So this is a lack of diversity. And taking this into account, I reflect upon my career and what I have tried to do in various aspects of these issues that reflect upon what is going to impact the healthcare of our children, particularly those that come from minority backgrounds. So I'd like to briefly go through with you issues that I've addressed with regard to health disparity research, diversity in medical education, clinical care for underserved, and advocacy and leadership training. I have been fortunate to work with great colleagues throughout my career at Stanford, and among them, most recently, our colleagues at the Immigration Policy Lab. This is the political science lab that Dr. Lee Sanders and I have developed a partnership with to look at issues of immigration. And with the support of the MCHRI grant that we received to do this, we were able to work with a group both at the Immigration Policy Lab and people across the country. In this case, we brought together Stanford political science, sociology, and pediatrics, along with obstetricians at Duke and Oregon, and tried to understand some of the effects of immigration policy on mothers. So this study that we did that was published in Science looked at the issue of what happens when you give a undocumented mother DACA. Does that provide benefits for the US-born child compared to those mothers that don't receive DACA? And what our study showed is that mothers that received DACA had children that had 50% reduction in anxiety and adjustment disorder compared to those that did not. So this was really quite significant. And to the point at the time that this was an issue and still is, this information was very important for people in policy. The Attorney General of California used our study to develop a brief for DACA support in California. We have continued to do this work, and we have studies that are looking and been recently published in JAMA Peds, looking at the public health insurance expansion for immigrant children and interstate migration of low-income immigrants. This concern is about whether you give insurance, health insurance to immigrants, does that bring others from other states? The answer to that is no. And that is really important for health policy makers to know that they can go ahead and provide services for immigrant children. We continue to do this work in other areas, looking at intergenerational effects of DACA and also the limited English proficient families and what impact that communication issue has with their physicians. More recently, because of this work, we got a NIH grant that is starting in 2020, will go to 2024, looking at the impact of federal and state legislation. The other aspect of my career has been one of working with students and trainees, and I've been, as I said, a dean since 1983. One of the important programs that I think I've been part of is developing the Early Matric program, which is a pre-faculty pipeline program since 1984. That program has now produced faculty across the country, senior faculty that are doing great work in everything from genomics to radiation oncology, to cardiovascular disease, to medical education. So it makes me very proud to say that given the chance, these students can be very successful. And I've been lucky enough to be part of that. That program has been supported both by the school, but also by grants from the Center of Excellence, which is a HRSA grant process that we've had for the last 30 years. And that grant has provided us the opportunity to do pipeline leadership and social justice. And moreover, as this activity over the last 30 years has happened, we've been able to develop within the Stanford Medical School a sense that all these things have to be part of the institution. And therefore, Dean Miner and Gesundheit have developed the Office of Diversity in Medical Education, where all this activity is going to be part of the Stanford Medical School. The other aspect that I've been very proud of working with is our fellows that we have developed. And a number of them are still faculty here. And that group represented by Dr. Chamberlain, Sanders, Stewart, and Weintraub have been really quite successful in advancing the care for underserved populations. The other aspect of my career has led me to do national work on issues of diversity in departments of pediatrics. And we did one of the first studies nationally of this work, which shows that pediatrics is doing some good work, but needs to get better. In addition to the work in trainees, I've done work with the issue of what kind of curriculum do we need to do for our medical students and trainees in general. And we've developed work on issues of unconscious bias. This are modules that we've developed with these topics being addressed. And moreover, I'm very proud to say that the school is taking this on even more so. And within the Office of Medical Education, Diversity Medical Education, they are developing a whole curriculum on social determinants and social justice for all of our medical students. This work is being led by my colleague, Dr. Rena Thomas. In addition—
1 minute, Dr. Mendoza. Thank you.
In addition to transforming research and education, clinical care is really important as well. And we develop partnerships with a variety of groups. The Gardner-Packard Clinic is a community clinic that's been partnered with us, partnering with other individuals in the community to provide services with underserved communities, underserved children. Looking at the medical legal partnership, bringing in lawyers to help our patients, working with the community as a whole with volunteers. But I think in the final analysis, to me, the other aspect of transformation is providing leaders to do that transformation. And as I said, I've started to look at this early on in individuals' careers and getting them involved with leadership and development of the leadership as medical students. But my colleagues, Lisa Chamberlain, have done this through residents, and other colleagues, Drs. Powell and Yamani, have done a similar kind of program that I've been able to help with in the areas of junior faculty and fellows. So I think at the end of the day, what we have is a need for transformation of our research, education, clinical care, and advocacy. And I think Packard and Stanford Pediatrics is going to lead this because we have the next generations of leaders. Thank you.
Thank you so much, Dr. Mendoza, for that wonderful presentation. Just a reminder to the audience, if you have any questions, please do use Slido to type your question. I would like to start with the first question. Are there any unconscious bias learning module available to anyone that you would recommend? I don't know if there's a centralized reference that you can refer people in the audience to.
Well, certainly the ones that we've developed have been used by other schools, but I think this is an area that's developing more. And I think as the Institute of Medicine suggested, we need to address this even to a greater extent than we have. Their work has shown that it does impact clinical care. And I think it's important for us to think about precision health as not only understanding the disease process, but the individual and how they come to the clinical environment. So I think that every school should have this. There are many programs across the country, and I would suggest that looking at some of the other schools would be appropriate.
Great. Thank you so much, Dr. Mendoza. Thank you for all the wonderful work that you've done over the years, especially in the area of promoting diversity in the pediatrics workforce. Just for the interest of time, I'm gonna now like to introduce our next speaker. It is my great pleasure to introduce Dr. Juno Obedin-Maliver. She is an assistant professor in Obstetrics and Gynecology, and she will be talking about reconceptualizing maternal and child health research for people of all genders and sexual orientation.
Hi, it's my pleasure and honor to be here, and thank you so much to the attendees, to the organizers of this event. As mentioned, my name is Juno Obedin-Maliver, and I'm hoping to inspire you to ask better questions in your research design and execution towards equity. Thank you, Dr. Mendoza, for that important framing with respect to race and ethnicity. And this is going to be speaking about another dimension of diversity with respect to sexual and gender minority people, which include but are not limited to people who are lesbian, gay, bisexual, transgender, queer, and or intersex. This work was supported by the Society of Family Planning, NIH, PCORI, and importantly, the Maternal Child Health Research Institute. Very grateful to my funders. No other significant conflicts of interest. So as we get into this, I think it's important to start with examining what our norms are. When I say pregnant person, what do you envision? Probably somebody like this, and you can go ahead and click. And this image is so emboldened in our mind that we have stamped it into even on our medication. So please click again. And this is a common nausea medication. But what if I showed you a pregnant person like this? Click again. Now, by extension, what does a family look like? Go ahead and click. Probably you're used to seeing something like this. Go ahead and click. A mom, a dad, 2 kids. It's so enshrined in our world that you even see this on restroom signs. But then what if I showed you families like this? So this is Wiley and Stefan, 2 gay men, one of whom is a transgender man who carried his own pregnancy, or the lesbian couple. Next click. And then what is the implications for these assumptions about what we're used to thinking about in terms of individuals who might be pregnant and or in terms of their family and gendered norms and how this goes into our medicine and science. You can go ahead and click. So this was a boy who was unfortunately ridiculed for his desire to wear nail polish in his just in his life. And you might say, gosh, leave that kid alone. But what would happen if one of our CEOs, for example, click again, walked in wearing a suit, nail polish, maybe lipstick? Would it really like trigger something in your mind, the back of your mind, and bother you a little bit? And I would say even for folks who are very comfortable in this space, it would, because we are so normed on certain genders kind of constructs. What if you saw, and you can click again through all of these to make the point. What if you saw a woman playing football? Somebody walked into the bathroom that you were in that you thought was of a different gender than you are. And how does this play out in terms of our medicine and research? We know, for example, that heart attack symptoms are different in men and women. And this has to do with people's sex assigned at birth as well as gender. Next slide. So I want to introduce to you the gender elephant. Now, in some ways, this may be the elephant in the room, and I think it's a useful tool. And it speaks to these different domains that are operating all at the same time. So gender identity is one's internal sense of being a man, woman, neither of these, both, or another gender. And this could change throughout people's lives. You can only know somebody's gender identity by asking them. It's an internal experience. And this is different than somebody's gender expression, how they speak, their vocal intonations, cross their legs, hair, makeup, etc. Again, these can also change, but you won't, this is how somebody reads, and there are common perceptions of what is appropriate for gender perception at a particular time and particular cultures. This is all different than somebody's sex assigned at birth. The assignment and classification of people as male, female, intersex, or another sex based on a combination of anatomy, hormones, chromosomes. It's important to say that we don't use the word sex without qualifying it first, because sex could be, a process, engagement in terms of a certain behavior, and it's often conflated with gender. And that's different yet again from who somebody's physically attracted to, emotionally involved with, and or their organs, who they're sexually involved with in terms of behavior. So next slide. We'll begin with an illustration in terms of thinking about sexual and reproductive health. The case of Sam. He is a transgender man who is brought into the ED with 8 hours of severe intermittent abdominal pain by his boyfriend. It had been several years since he menstruated. And though he was previously on testosterone, he'd stopped taking it because he lost his insurance. He actually took a home pregnancy test, which was positive, and he thought that it might be a mistake. Despite coming to the emergency room and telling people he was a transgender man with the capacity to be pregnant, And even though he had a positive pregnancy test, he was not treated as a pregnant person. And there were delays in diagnosing Sam as pregnant. And ultimately, he was found to be in labor with a cord prolapse, which is an emergency medical condition. And sadly, he suffered a fetal demise in a stillborn baby. So despite telling providers he was a transgender man, there was such incredible cognitive dissonance that pregnancy protocols were not employed. And so this is a sad story, but certainly there are other stories. You can click the next, like ones of joy, planned pregnancy, family building among transgender and gender expansive folks, or the larger sexual and gender minority community, that led me to think more about what is the experience of sexual and gender minority people as they seek to build families or choose not to? What is the experience of sexual and gender minority people as they're seeking sexual and reproductive health care for themselves? And what do we understand about their experiences? Next slide. In the interest of time, I'll just briefly say our systems reinforce limits and patterns that make it very difficult to disentangle those dimensions of sex, gender, sex assigned at birth, and sexual orientation, really thwarting clinicians, researchers with guidelines. So next slide. You may be wondering, how much does this apply to me? I really work on maternal child health, and I see, women who were assigned female sex at birth and whatnot. But I will say that we have very good estimates overall that sexual and gender minority people make up at least 4.5% of the population, or 1 in 22 people. And those differs in different regions of the country. Data on transgender people are less robust, but we estimate about 1 in 200 people. So whether it's among parents or children, faculty, staff, and colleagues, LGBTQ plus people or sexual and gender minority people are all around you. Next slide. And we think that these numbers are even growing, partially because of social acceptance, but also because, and therefore people's willingness to talk about quote unquote non-normative identities and experiences, but also because of changing gender norms. A recent set of results from the California Health Interview Survey showed that about 27% of youth were considered gender non-conforming. Now, that does not mean that they're transgender or gender minorities, but it does signal a change in gender categories. And you can click, that's about 800,000 youth. So, next slide. I was tasked with thinking about, and talking about challenges and opportunities with changing research in the Maternal Child Health Research Institute space. And I think this is also important, not just because it's frankly the right thing to do to think about more sexual and gender minority diversity within our clinical care and research, and therefore interventions, but also because it increases accuracy and completeness of scientific data collected through research of sexual and or gender minority communities and everyone. Much of my work is focused on sexual and reproductive health and its organ-dependent outcomes, like pregnancy-related events, things like pregnancy desires, complications, unintended pregnancy contraception, et cetera. And most of this research has been conducted among quote-unquote women and straight couples, presumably cisgender, although almost never specified. As a result, many LGBTQ people have either been explicitly or implicitly excluded from that research, and which is geared only towards women and straight couples. And others have opted out because of concerns of being offended or erased in research questions. Next slide. So this was reflected in one of my participants in a research study when we were starting to think about how do we investigate sexual and reproductive health questions among sexual and gender minority people with the community. And they said this: it's like if you started a conversation talking about female this and woman that, or only male and female, just a simple statement of quote unquote female reproductive system, or what is so triggering for gender expansive folks and trans people is that, like, regardless of what comes after that, there's already a disconnect. That's like, this person is basic as F, excuse the language, but this is what the participant said, and they don't understand who I am. Okay, next slide. And so to address this and just make this more complete, I have a few examples here from major national surveys about various aspects of family planning. One from the National Survey on Family Growth is a question that reads, and what about your partner? At the time you became pregnant, did he want you to have another baby at some time? Or the following one from the Behavioral Risk Factor Surveillance Survey that says, did you or your partner do anything last time you had sex to keep you from getting pregnant? Next slide. So perhaps what's immediately apparent to some of you, there's implicit bias in each of these questions that assumes something about the reproductive respondents' sexual orientation and gender identity, or that of their partners. Our team became increasingly concerned about what we were missing in the world of sexual and reproductive health research because of this ubiquity of these assumptions in our research methods, and whether you focus on sexual reproductive health or another domain, for example, even something like childhood cancers, these sorts of biases may well be present in your field and warrant attention. I encourage you to think about questions commonly asked in your field, and if or how some of these biases about who somebody's gender is, their sex assigned at birth, that of their parents, what parenting models look like, come up in your own work. Next slide. Another question from contraception world. This one pertains to the assessment of contraceptive use. Take note here of the implied meaning of the word sex and assumption of sexual activity. How consistently do you use birth control? Every time I have sex, most, etc. Next slide. So this is how we modified the question with our community involvement to say, how consistently do you use birth control when having sex where sperm is released in or near the vagina? Now, this is in keeping not only with a community engaged approach, but also being more scientifically accurate, because some types of sexual activity can result in pregnancy and some cannot. And that the only time that results in pregnancy is where sperm is released in or near the vagina. We also wanted to acknowledge that not everybody has sex in a way that where sperm is released in or near the vagina, or sperm or sex at all. And so we have to be allowing for more options, both in our question stems and in our answer choices, so that we make sure that we're reflecting the diversity of who we're serving and trying to understand. Next slide. So there's a lot to be said about the results that came from these surveys, and I'll show you the slides at the end that have some of the references. We fielded a survey to sexual and gender minority respondents who were assigned female sex or intersex at birth, and about 3,100 of them. They were very diverse in terms of gender identity, with over 60% having multiple gender identities, and also diverse in terms of sexual orientation, similarly 60% endorsing multiple sexual orientations. And then when we looked specifically to highlight, just give you a little insight at the transgender and gender expansive people, about whom there were almost 1,700, 54% of those people were parents. And 12% had ever been pregnant, with another 11% desiring a future pregnancy, with a pregnancy incidence of 16.8 pregnancies per 1,000 people. So this is uncommonly thought about in our research and in our clinical care, the sexual and reproductive lives of LGBTQ plus or SGM people. And I've been using those terms interchangeably, and happy to discuss the delineations of those terms in the future. But this is just to highlight that there's a lot we don't know, because we are not looking at the full spectrum of people's gender identities, sex assigned at birth, and sexual orientation. Okay, so next slide. So now, afforded by both administrative changes in California birth certificates and a generous grant from the Maternal Child Health Research Institute, we're working to map different parental structures in California. And this was facilitated by the fact that in 2016, birth certificates now allow a category for mother, father, and parent designations under whether somebody is a parent giving birth or a parent not giving birth. Now, this is not foolproof, but allows some visibility into the lives of LGBTQ plus parents and relationships to risk factors, obstetric and neonatal outcomes, and these are forthcoming. Now, in this table, you will see that the bolded rows indicate those couples where we're pretty confident these are SGM couples, or high likelihood of them being there. Now, people are not endorsing an SGM identity here, but this is a way to look into these actually limited data. Also, many SGM families may not look like, they only have two parents. So, going to the next slide, and to wrap up here, I realize that, because of a little bit of those technical challenges, I didn't really delineate the difference between gender identity and sex assigned at birth. Very important, sex assigned at birth being, organs, physiology, etc., versus somebody's internal experience of gender versus their gender expression. And so I want to challenge everybody in this opportunity to do better science and think about, when do you most commonly conflate sex assigned at birth and gender identity and or expression in your work? We all do it. We are all trained to do it. My 3-year-old is trained to do it in every book that he has. And so think about when we're making these assumptions, and also when do you assume that individuals' gender identity, expression, sex assigned at birth, and sexual orientation all line up as society expects. So the pictures and families that I showed you of men being pregnant or 2 women being mothers, these questions, we're expecting a certain lineup, and then we're thrown for a loop when those things don't line up. And how are you assuming particular family structures and gendered roles? So what do your intake forms look like? Does it just say maternal history and paternal history? What if there are more parents involved? And importantly, are you asking sex assigned at birth, gender identity, sexual orientation, and pronouns of all people that you are working with, either in investigation or clinical care? So I will go to the last slide here, and next slide. To learn a little bit more about some of the research that's published that highlights the differences between sex assigned at birth, gender identity, sexual orientation, etc. These are a few of the references. You can also look at the pridestudy.org and our research page to learn more about our research there, and then keep your eyes peeled for our future MCHRI research outcomes. Thank you for your patience, especially with the technical difficulties here, and I'm happy to share slides if people would look forward to them in the future.
Great, thank you so much, Juno, for that very illuminating talk. I'm so sorry about the technical difficulty, but unfortunately, we don't have enough time for questions. So I would encourage anyone who have questions for Juno, please reach out to us, and or you can continue to post questions in Slido and we'll pass it on to her. So next, I would like to transition to my colleague, Venkat Krishnan, on the MCHRI committee, who will introduce our next speaker.
Hello, good afternoon, everyone. I hope you can hear me. It is my pleasure to introduce the next speaker, Dr. Anantha Adella. And if you're up, so just as a brief introduction, she's an instructor in pediatrics, endocrinology, and diabetes, physician scientist working in disparities in type 1 diabetes and management and outcomes. So please take it away if you're ready.
Hi, everyone. Thank you for having me give this talk on provider implicit bias and the healthcare provision. And I am going to tell you just one story in the medical field at large, and that's the pediatric diabetes inequity story. So Juno actually did a very nice job setting up part of my talk, obviously, so did all the speakers, but specifically with that ending thought that she left you with, which is sort of what assumptions do we make, and how does that really translate to changes in the care that we provide? So that's essentially the foundation of the talk that I'll be giving. And funding for this work is including the publications that I've done was during my fellowship, so it was supported by MCHRI as the provider implicit bias work itself. And I'm supported by an NIATDK K-12 at this time. and have no relevant disclosures. So what I'm going to do is kind of start you a bit stratospheric and just talk about health disparities in America, because like I said, I'm going to tell you one story, but chances are this story exists in whatever niche or subspecialty or broad specialty that you care for. So the first is, disparity into the adult world, and heart attacks and MIs probably get the most popularity, both within medicine, within medical education, but also across the globe. And we just have found that, and this is from the same Institute of Medicine report that was referenced earlier, that Black patients are 33% less likely to receive appropriate intervention after a heart attack than white counterparts. And that's 1 in 3 Black individuals in America can expect to not receive standard of care. And in the last 2 to 3 years, it's been exceedingly clear that irrespective of socioeconomic status, Black women's mortality with regards to maternal mortality is 3.2 times higher than white women. And this is again something that has worsened, is specifically what's documented in there. And these data are available in many places, but feel free to ask me for it. And this is maternal child, so I started with the maternal, and the child is the infant mortality distribution by race ethnicity, starting with non-Hispanic Black. So this is mortality rates per 1,000 live births, and the highest being in non-Hispanic Blacks, and the lowest being in Asian and non-Hispanic whites. And so you can really see a pretty clear, particularly in the people who identify as Native Alaskan or Native Hawaiian and Pacific Islander and non-Hispanic Black, they have markedly higher rates of infant mortality. And so that's kind of the lay. And then when you look really, so there was a study that looked at 3,000 pediatric visits for abdominal pain. And what they found was when you had diagnoses such as appendicitis or other surgical indications, Black and Hispanic children were less likely to receive pain medication or narcotics, even when the pain was reported as severe, and even when it was graded as the same as their as the white counterparts that they were comparing them to. And so that's in general pediatrics. Coming into not my subspecialty, but is pediatric nephrology, in a large study that came out of Southern California looking at pediatric dialysis. They found that Black individuals had 64% higher mortality and were 72% less likely to receive a renal transplant. And when you looked at Latinx or Hispanic individuals, they were 57% less likely to receive a renal transplant. And this was in compared certainly to their non-Hispanic white counterparts. And so what the goal of these set of slides is to show you that this disparity, it's very, very broad. And I'm going to hone in, because as you heard in the introduction, and a lot of my work has been in pediatric type 1 diabetes, but again, this is not a unique niche problem that only exists in pediatric type 1. So what I'm going to do next is introduce you to where the disparities sit. So insulin pumps are used to help make blood sugar management easier in pediatric diabetes and are associated with improved glucose outcomes. And what we have here is a paper that came out in 2015, which is actually the first time that really truly critically endocrinologists and diabetologists had looked at race ethnicity as an impact. And here you have that the red bars are non-Hispanic white, the yellow bars are Hispanic, non-Hispanic Black, and then the green bars are Hispanic individuals. They use the US Census Bureau ways, and that's typically how most of these studies have classified race ethnicity. So I'll also refer to it as the race that was preferred to, as they self-reported, rather than always changing it to Latinx, though that might be sometimes a preferred nomenclature. So here what you have is the insulin pump, which are known to show improvements in glucose outcomes. You can see here about a significant difference between minorities. And when you look at non-Hispanic Blacks, severe hypoglycemia is a really important marker because it's associated with cognitive outcomes and also is associated with high risk of morbidity. And you have here that non-Hispanic Blacks have about twice the rates of severe hypoglycemia than others. Diabetic ketoacidosis is a very preventable and life-threatening complication that is associated, and I've abbreviated it here, DKA, that's associated in type 1 diabetes with many poor outcomes. And in this was the first time it was documented that Black children, this was all American children that were looked at, had 3 times greater rates of diabetic ketoacidosis, which can cause, which in the most severe cases can cause, comas and death, and it is twice as higher in Hispanic individuals. And finally, the hemoglobin A1C is a 3-month average glucose marker, where our targets are less than 7.5 is what we aim for. In general, Americans don't do the greatest job overall kind of meeting the targets, but what we can see is a difference, and these were all statistically significant in their differences by race ethnicity. So I think when you really kind of look carefully, you can see a race ethnicity difference. And what we did was we looked at continuous glucose monitors are an emerging kind of standard of care for pediatric type 1 diabetes. What glucose monitors do is they essentially give you a blood sugar every 5 minutes, and just the use of glucose monitors have shown an improvement in hemoglobin A1C. So what we did was we looked at this is all Stanford data here, and we looked at individuals who have public insurance only. So now this is a socioeconomic lens, but again, there is a significant racial overlay here as well, but racial ethnic overlay. And what we did was we classified our youth into never users, consistent users, if they had to stop, and whether they stopped using glucose monitors because of insurance or because they just didn't want to. There are many reasons why one might not want to use a continuous glucose monitor, and we felt that it was important to delineate those. And what we found is that there was a statistical significance between those who used CGM versus those who didn't. And what we found, though, is that there does seem to be this kind of drift upwards, and there's not statistical significance here if they had used the CGM but then stopped. And so our question was really, what happens after somebody loses CGM? And the reason why this question was really important to ask is because youth who have public insurance are much more likely to have sputtering and stop and go coverage. And so we noticed that is much more common than our privately insured youth. So we took about 1,000 visits and we bucketed them into different, we either said, okay, this is the visit right after you start your continuous glucose monitor, your CGM, and then you have continuous use. You had use in the visit before and you have use in the visit now, or you had this initial loss. You had use in the visit before, but you don't right now. So this was the first time you lost it. This continued loss of CGM says you had use before, or you had loss before and you still do. And then this unique category, you lost your CGM, but you've now regained it. And we wanted to see, how does this hemoglobin A1C, where about anything above 0.3 is worth of a difference between before and after is worth noting, and anything 0.5 is, slam dunk, really helpful. How does this change? And what we find is after you start a CGM, you see that beautiful improvement that you see everywhere else. But once you start seeing some interruptions, including if you regain your CGM, that loss trajectory just seems to continue. And again, this is important because it's a policy consideration. We really need to make sure our kids who have public insurance are getting continuous glucose monitor access, because there is an improvement. There's a clinically and statistically significant improvement. But the other piece is, to date, most studies that have looked at youth who use continuous glucose monitors and have public insurance don't show a consistent benefit. And I would argue that what they're doing is not accounting for the loss here of CGM and the fact that these children consistently experience more barriers to being able to continue that are purely paperwork related. About 60% of our discontinuation, 65 was due to insurance related reasons. And looking even more, so these data about type 1 diabetes, technology use and socioeconomic status. We looked at data from the Type 1 Diabetes Exchange, and we actually, there's a little too much to cover in here, but we compared ourselves to our German cohorts. And what we did was we took all of the kids, there's thousands of children that are in this registry, and we said, you have the highest socioeconomic quintile or you have the lowest. And then we looked at a few different important diabetes measures, and we looked at it 2 time frames. The light blue is 2010 to 2012, and the dark blue is 2016 to 2018, so more recent. And what you find is that those in the highest socioeconomic quintile had the most pump use then and now, and those in the lowest had the lowest use then and now. You can see that there's been an increase, but that increase still maintained the disparity. I'll tell you that when we compared ourselves to our German colleagues, there was essentially a flat line here. The slope that tells you that there's a socioeconomic difference wasn't as pronounced. And when you look at, this is continuous glucose monitor use, so this was insulin pump use, and this is continuous glucose monitor use. Between 2012 and 2016, continuous glucose monitoring the technology itself has improved so much that its efficaciousness is also improved. So now you have an efficacious and effective device. And what we're showing here is that the highest quintile had a preferential uptake when compared to the lowest quintile. You guys can appreciate overall that the slopes are now different, whereas here the slopes were more similar. And so now you have differential access to an efficacious treatment, which is essentially the equation for where inequities start. And you can start seeing it because the hemoglobin A1C, which is the primary glucose outcome that we look at in type 1 diabetes, you can see that between, this is the highest socioeconomic status, had the lowest hemoglobin A1C. And I told you that 0.3 to 0.5 is clinically significant. And if you look here, this is about 7 point, let's even round to 8 versus, 9.2 or 3. So that's almost a 1+ hemoglobin A1C percent difference, which does translate to significant outcomes as far as microvascular, macrovascular, long-term, adult complications. And so this is not a passing amount. And what you see here, and hopefully you can appreciate, is that not only was there this slope back in 2010 to 2012, but if you look, this slope has actually increased, much like the CGM, which is telling us that now that our poorest children are doing worse than they were compared to their higher socioeconomic peers than they were about a decade ago. And the question is, if you remove the effective diabetes technology, because the innovation in that has just been game-changing, what happens, and this is the effect once you remove technology. And what you can see here is that, yes, absolutely the disparity exists, but what you can see is that there is a difference in the overall amount that the disparity actually counts. I'm going to move a little bit fast. I just realized that I got very excited about what we were talking about. And I think I'm going to just take a moment, though, to define implicit bias for you guys, because really the question was, why do all those inequities exist? And I think the answer is multifold, but implicit bias is certainly one of them, which is both the unconscious and systematic. It's both the discrimination, but also a promotion of a certain subgroup. So you may sometimes comes from a good place. Oh, I don't want to burden the family more, so why offer them this? Sometimes it comes from, I don't think they can handle it, so I don't want to do it. But regardless, it's one group that's systematically addressed differently. I'm going to skip over some implicit bias examples that I had, but I do want to pause a moment on the fact that they come from these physician perceptions of Black Americans. And this is highlighted in the Institute of Medicine report that was also referenced earlier. And the reason the Institute of Medicine hasn't updated its overall position is because it has actually come out and said that things are not that different. And they do feel that they are less pleasant, less intelligent, that they are more prone to problems with adherence and alcohol and drug abuse. And so this really, knowing this implicit bias literature and having seen the inequities both personally in clinic and at a national and kind of international level, was the impetus for the Gatekeeper study, which is basically assessing and addressing the role of provider implicit bias on diabetes technology recommendations in pediatrics. So I'll do a very brief study overview. I developed essentially a targeted implicit bias for pediatric diabetes technology. So it's highly specific, and we developed that tool, and we recruited 39 providers. And we then gave them an educational intervention on implicit bias, and then we administered this new diabetes technology implicit bias tool. And I can take questions or talk about how that was developed, but I'll kind of cut to the chase here. So we had overall 39 people who were recruited, mean age of about 44. And I'll get to who, and as you can see, we'll actually do the punchline now, which is about 33% of the people flagged as having insurance-mediated bias, whereas 6 people did not. So if you recommended, what I did was we had people weigh in insurance in pediatrics and diabetes technology coverage. It's actually, it's spotty, but technically you can get coverage. And so it shouldn't be a barrier, and it shouldn't be a reason to not offer someone technology. And what we found is that 33 of my 39 participants, and we were approximating about 65 to 70% bias given what the rates in the literature are, but mine's closer to 86 in the sample. And you can, there's a kind of female predominance in my respondents, and primarily non-Hispanic white. These red numbers are when in a univariate analysis, there was a statistical difference between the bias and non-bias. So in a univariate analysis, group comparison, you were slightly more likely to have bias if you were non-Hispanic white. And then the other one, if you come all the way down here, is the number of years in practice. I really want to call out that there is not a significant difference by age. So it really, many times people think years in practice and they think age. We also looked at, what kind of provider are you? Are you a physician, a nurse practitioner, or diabetes educators? Because these are the three major groups that introduce technology to our participants. And then, do you have a personal history of diabetes? Where do you work? And do you see is there a difference? If you see more publicly insured, maybe you're more likely to understand that that's not an issue. But none of those were really differences. And part of the education module included taking a well-established implicit bias, broad implicit bias test called the Implicit Association test, which you can go take too if you haven't already. And what we found is I had them do the light skin to dark skin. There's like a skin color one, there's black and white, there's by obesity, there's by sex, there's many. But I had them do, particularly because we have a large, Latinx population here, I wanted them to do the skin color one. And you can see nearly all of them had at least a mild to strong, but most commonly moderate preference for light skin. No one had an automatic preference for dark skin. So you can see that even in the prior validated study that the percentages actually come out to about the same, about 8 to 10% who don't have any. And so that was telling. And then we had them kind of rank, what is the most important to you? So this is the lowest priority. So they, the statement is that race ethnicity is the lowest for recommending insulin pumps. And insurance kind of came in third, although there's really very little insurance related barriers. And family preference appropriately was ranked first. But this is sort of where implicit bias shows up. It shows up in the grays rather than sort of in the light, if you will. And when you talk about continuous glucose monitoring, which again, I think is really emerging as, and I'm not alone in this, emerging as the ideal, insurance was ranked very, very heavily, even though, again, it's not a major factor. And I'll tell you that in the multivariate analysis, the only thing that really came out to be significant was really the years in practice. So the longer you're in practice, the more likely you are to go ahead and be less likely to make those recommendations. So I'm just going to leave the closing thought here, trying to be mindful of the time, which is that, again, like I said, this is just one story of pediatric inequity in diabetes technology specifically. So the question is, look at your field, think about it, and where is your story, and can we have some other work being done? And so I just want to thank MCHRI and my mentors, Dr. Hood and Dr. Moss, and the whole gang. So I'll stop there.
Thank you so much. That was exciting work. Thank you so much for sharing it with us. In the interest of time, however, we will have to move on, and you can review the questions, if any, on Slido, please. Thank you to all the audience, and that will wrap up this afternoon's session for now. However, I would like to remind everyone that we can now transition to our second poster session, where there's a lot of exciting work being discussed, and the poster session is from 12:30 to 1:15. So please check out these amazing posters, and you can meet with the presenters with the Zoom link that's listed on the poster session 2 webpage. Thank you so much for attending. Have a nice day.